Good afternoon, everyone. Welcome to the panel discussion, Healthcare for the Future. I'm Ramel Mustafa, professor at Ivy Business School and director of the Lawrence National Center for Policy and Management. At our center, we consider healthcare as central to our social infrastructure. And social infrastructure, in turn, is the bedrock for the development of other critical issues, from harnessing technological innovations to shaping our workplace, generating sustainable growth, and of course, unlocking Canada's competitive advantage to ensure our leading place in the world stage. Now, healthcare also touches every Canadian in every community, big and small, rural and urban, north and south, and east and west. At its core, our healthcare system was built to offer publicly funded universal coverage for necessary healthcare services based on need rather than ability to pay. For many years, this system was the envy to the world. Unfortunately, that is no longer the case anymore. Over the years, Canada's healthcare system has faced its fair share of challenges, with the global pandemic exacerbating existing cracks in its once sturdy foundation. From acute shortages of healthcare professionals to higher demand for medical services due to aging and increased population, there's evidence to suggest people are struggling to find access to even basic healthcare services, with more dire conditions in Indigenous, racialized, and remote communities. In fact, a recent poll shows that almost 70% of Canadians think our healthcare system has been on the decline over the last 10 years. On the slide here, projected, we have some other key points which I hope will inform our discussion today. We have also heard from our students and young alumni through the Ivy 100 Symposium competition on the numerous problems they see in our healthcare system, some of which they personally experienced. Many have underscored the need for bringing transformational solutions to this large and intricate challenge. At this forum, we don't want to just focus on understanding the main constraints, but also we hope to formulate a few key actionable solutions that, if implemented, can make a difference. All in all, we want to explore how Canada can create a pathway to develop, once again, a world-leading healthcare system. Of course, we won't get there in a year or two, but what can we do, starting from today, to help build the healthcare system that we would like to see by 2035? And who better to wrestle this important question than our very distinguished panelists we have convened today? And they really don't need any introduction. And in the interest of time, I'm just gonna do it very quickly. All the way from PEI, we have Dr. Heather Morrison, who is the Chief Public Health Officer of our province, Dr. Jane Philpott, former Federal Minister of Health and now the Dean of Faculty of Health Sciences and Director of the School of Medicine at Queen's University, and Dr. Kevin Smith, President and CEO, University Health Network. Now, steering this dynamic panel discussion is our center's Mahmood Nanji, who is the Power Corporation of Canada Fellow, and by the look of it, he's also a fully recovered senior federal and provincial bureaucrat. Mahmood has the envious task of leading this exciting discussion and the unenvious task of wrapping it up in just 35 minutes. Mahmood, over to you.
It's an absolute honor and pleasure to moderate this terrific panel on one of the most important public policy issues concerning Canadians. And as you heard this morning from our business leaders, it's also one of the biggest issues that they want governments to get right. So we have a dream team here, if you can say that. We have a former federal health minister and a leader in medical education. We have one of the best health CEOs in Canada, if not North America. And of course, we've got one of the most trusted public health officers in this country. These three exceptional leaders, along with thousands of dedicated healthcare workers, kept us and our loved ones safe over the past 3 years, which is why we're able to gather here today. So on behalf of the Ivy Business School, all of you, and Canadians from coast to coast to coast, I would like to take this opportunity to express our deep gratitude to all three of these leaders for their outstanding leadership dedication, and public service. Can we give them a big hand of applause? Okay, here's how we're going to approach this very easy topic. We're first going to talk a little bit about the major challenges facing our healthcare system. We're going to dive into some of those issues, and then what I'm going to do is I'm going to take a couple of questions from the floor, and we'll wrap it up by asking each of our expert panelists to give us some key takeaways or advice that they would give to decision makers. So Ramel had put up some rather sobering data there earlier. So when we think about today our healthcare system, it's often described as a system that's in crisis, in decline, and failing. I know every Canadian has a view about our healthcare system. We're going to ask our experts, from their perspective, what are the major challenges facing Canada's healthcare system? Jane, I'm going to start with you. You were a part of a significant paper that was released recently calling Taking Back Healthcare. So perhaps you can tell us what you think some of the biggest challenges are.
It's a pleasure to be here today. Nobody said in my intro that I'm a Western alum.
Oh, wow.
Medical school at Western. So I feel like that should be a big part of my bio at this event. Anyway, lovely to be here. Thank you for convening the panel. You know, where are the biggest challenges in the system? We could talk about that for a long time. I would actually like to point out that as dire as the data are that have just been shared, it's actually worse than what those data say. So the CIHI data, for example, this year has more recently been updated, and the people who don't have access to a front door to the healthcare system is actually much more than 3.5 million Canadians. So there's data that's come out of the University of Toronto and a group called Our Care that has actually done the analysis about across Canada, how many people don't have either a family doctor or a primary care nurse practitioner or any other place to access the health system other than Kevin's emergency department. And in fact, the numbers are much worse than your chart shows. About 22% of Canadians don't have access to health care. That now works out to about 7 million people. So we have built our healthcare system without a first floor. We have fantastic secondary and tertiary systems. They are under enormous amount of struggle. But actually the root of our problem, as it relates to health systems, is that we've never fully built out the primary care system and access for a place for people to go to get preventive care, to get chronic disease management, and to be able to get their ongoing needs met. And the result of that is it trickles down to every other part of the system. And I would argue that we have deceived ourselves because we've had national public health insurance, but it has only ensured access to doctors and hospitals. We have never actually had a national primary care system in the country, unlike many countries in Europe, which get much better health outcomes at a much lower cost per person. That's the work we've never done in Canada, and that's what we need to do immediately.
Thank you, Jane. Thanks for starting us on such a positive note. Kevin, and we're going to come in and dive into some of those issues that you've raised. Jane, Kevin, over to you.
Yeah, I totally endorse what Jane had to say. I think the foundations of healthcare for most Canadians is their relationship with a family practitioner or a primary care provider. It is not there. We need to rebuild or build that if it was ever there. Where we, the system, have to take some fault is it's always been a fairly disaggregated system. So if you were all primary care doctors today, no one could make a decision for you collectively. Jane could speak for you until she said one thing you didn't like, and then she wouldn't speak for you anymore. So part of what we're lacking is some structural opportunity for decision making. The other piece that I'd push hard on is an audience with a economic attention to economics is the productivity of our healthcare system. And scope of practice, as well as dramatic shortage of providers, is something we cannot escape any longer. We have people who are very expensive doing things that much less expensive people could do with joy, give them great jobs, great benefit plans, great retirement opportunities, call a pension. That would be a much better system than we have today. The reason we don't tend to do that historically, it has been very much the silo of professionalism or collective bargaining. And if we're really going to open this up and think about extenders, and others who can help us truly meet the needs of Canadians. And I'm not suggesting that we go to something that isn't being applied in the best places in the world. If we drew the line, there's a top 10 list, pick your favorite top 10. Newsweek has one. I like that because we're number 5, but there's one I'm sure that we're not on that I wouldn't like as much, but it would still be a good list. Look at the places like University Health Network, like the Mayo Clinic, like Mass General Hospital, like the Karolinska, pick your favorite healthcare system. You will see technicians, technologists, and extenders who are extremely good at delivering great outcomes and allowing very expensive, very highly skilled, and in great shortage clinicians to look over a larger population of people, which means, guess what, we're a more productive system, and productivity for Canada is something we need to make a lot of gains in.
Thank you, Kevin. We're going to come back to some of those issues with respect to disaggregated system and productivity of the healthcare system. Heather, over to you. So, you've got a smaller population, but an aging population. You've got lots of big issues there. Your perspectives from a public health perspective.
It's a pleasure to be here, and thank you very much. I think we have heard access, and access is whether you're in a city or in a rural community, small province, big province, access in a timely way, access to the right provider at the right in the right place. I mean, that is really a cross-country issue. The only other thing I might add is we talk about not having the first floor of primary care, but maybe we don't even have the basement, because from a public health point of view, most of the disease and the morbidity in this country is related to 4 big diseases: COPD, chronic obstructive pulmonary disease, lung disease, cardiovascular disease, cancer, and diabetes. Now, of those 4 big ones, we have almost 75% we can do something about with modifiable risk factors. And as Canadians, that is not wanting to address smoking, physical inactivity, unhealthy eating, and harmful use of alcohol. So if we want to make a difference to the health of Canadians and to the health of each of our provinces and territories, we need to focus on those risk factors with good policy, et cetera, as maybe the basement, to take on that analogy.
Let's talk a little bit about the pandemic and something I suspect people like Kevin keeps you awake at night, which is the issue of talent and staff shortages. As we speak today, there's 80,000 workers in Quebec who are on strike. Their concern isn't just about being paid properly, but it's also about conditions of work as well, too. One of the biggest issues coming out of the pandemic is burnout and the exodus from the health profession. How do we address this issue of staffing shortages? Is immigration going to fill part of that gap? Do we need to take a very different approach around medical education? Kevin, I'm going to start with you.
As long as I've been in the sector, we need to take a very different approach about everything would be the historical construct. So I started out my career at McMaster, which did a revolutionary thing 35 or more than that, 50 years ago, by saying, let's take a science-based curriculum and actually turn it on its head and turn it into a problem-based curriculum that actually looks like what our patients' needs are. Let's not be so narrow-minded about who can go into medicine. In the old days, it was people with a scientific background. 50 years ago, McMaster said, not necessary. But these students succeed in spite of us more than because of us. They are remarkable people who you put in any system, they'll do unbelievably well. So I think our curriculum needs to evolve. If I really look at it, are we helping to graduate people to go where we need them? We're still pretty hospital-focused, as opposed to really saying, if you look at the population health of those most at risk. So what will make you most at risk? Poverty, number 1. Child trauma, number 2. Mental health and addiction issues, number 3. All of the social issues. So most of what we're talking about, we have an illness care system, not a healthcare system. If we're going to shift that, we'll always need the healthcare providers, and they're very highly skilled. Where I work, some of the most highly skilled, technically adept people in our country. Remarkable people. But we touch a small number of people, relatively. How many of you have been an inpatient in a hospital in the last year? If you want to share that information. Very small number. How many of you have had or wanted to talk to a family doctor or a nurse practitioner or gone to an emergency room? A lot more, right? So, when I look at one of the most exciting things I'm doing at University Health Network has nothing to do with the big, sexy transplant, cardiac, neuro programs. It's the first prescribing program in Canada for social housing. We're going to open the first 51 units of prescribable housing because we have 230 people, the same 230 people, who come to one of our emergency rooms 15,000 times in 1 year. Now just think about that. You'd have to come more than once a week. They're not coming because they have a medical emergency. They're coming because they have nowhere else to go. So if we can start looking at populations most at risk and populations who've been marginalized with your data from, I quibble with the Commonwealth Fund's ranking of kids.
I'm sure you would.
But that's a different debate for a different day. But when you look at where we really do badly, it is actually mostly on Indigenous population, primary care access, and subpopulations who really suffer the ill effects of poverty and mental health and addiction. And that's a focus where I think probably we three are going to be pretty closely aligned. If the basement is public health, the sub-basement, the lines that actually bring the electricity to the house are mental health, addictions, and social cohesion.
Very true. Jane, your thoughts on this?
Well, first of all, I want to just pause for a second and just say, I think that what Kevin and the team are doing at U810 around the prescription of housing is one of the best innovations I've seen in healthcare in a very long time. So huge kudos to you for that. That's incredible. We need to see much more of that kind of creativity. But I very much agree with some of the solutions you've talked about in terms of health workforce as the challenge, and teams and expanded scope of work is absolutely part of that, making sure everybody can work to the top of their scope. But I guess I want to say something that's a little bit more optimistic than perhaps my last comment, just to let people know that there are great things happening. I am actually really impressed with what's happening across the country around the expansion of the health workforce, and it's happening in multiple ways. It's happening in part through immigration. The College of Physicians and Surgeons of Ontario doubled the number of internationally educated physicians that they licensed this year compared to last year. And we're seeing that happen everywhere, that both internationally educated physicians and nurses are getting access to licenses more quickly. International medical graduates are getting better access to our residency program. So there's a lot happening there, but we are not going to solve our health workforce crisis off the backs of countries that probably need those doctors and nurses more than we do. So we need to do more ourselves. The good news is we are doing a lot more. Every medical school in this province and most medical schools in the country are in growth mode, and sometimes very large growth mode. Same thing's happening in nursing. Even better than that, though, is that not only are we growing our numbers, we're actually changing the way we do business. So just as McMaster innovated half a century ago around what medical education looks like, I can tell you that there's a lot of innovation happening in how we educate. We've got a program, for example, where we've started a campus of the Queen's University Medical School now in Oshawa with partners at Lakeridge Health, where we're actually training doctors for whom the candidates that apply have to commit to becoming family doctors. And we've actually built a family medicine fit-for-purpose curriculum in the community using life cycle case-based modules where the training is by family doctors and they get out into the community very quickly. So I could spend a lot of time telling you the great things that are happening at the schools across the country, but we are starting to train differently. Still, we will never be able to train the kind of numbers that are needed if we actually think that we're going to be able to do business as usual. We're going to have to be much more creative around how people work together, and there's no way that we'll be able to build the health workforce for the future without much better collaboration and much more task shifting in the system.
Thank you, Jane. Heather, your thoughts. I know PI has struggled with staffing issues and emergency wards being closed. You've got lots of remote communities. How is PI approaching this?
Well, I mean, I think one of the things that they're doing is they have plans to open up a medical school campus associated with Memorial, really trying to see if we can attract more people, but also keep them there. And they have family medicine residency programs. So it's really picking up on those same points, trying to increase the numbers, but also where people are training. We know where people train as residents has a really big impact, probably more than medical school training, but where they do residency. So I would be arguing for more spots in those residency, whether they are from immigration or foreign trained or not. But how we practice and how we let our healthcare workers and our physicians have more flexibility and change and not do just one kind of family practice where they go to work 5 days a week, where they get a chance to do different things that they are enjoying. We're going to keep them doing the job for a longer period of time. When we look at 86.5% of healthcare workers felt more stressed during the pandemic, I think they feel that way all the time. And I would count myself as one of those. And I think trying to protect them from some difficult times, and I think we've seen so much kindness around the country, but we've also seen some really hard things too. That people who go into healthcare do not do so because they want to be berated on social media or as healthcare leaders and physician healthcare leaders and be subject to threats, et cetera. And so if we are going to make sure that we don't have an even more stressed workforce, we need to make sure we train them, but also look after them when they're out the other side.
Thank you, Heather. And Kevin, remind me if I'm wrong, but I think you termed it the incivility of today's patients, right?
Both. Right?
Yeah.
Providers and patients.
And patients, yeah.
So
yeah.
our violence in our emergency rooms is up 500%, right? Like that's a remarkable difference. So when Jane and Heather are talking about how do you recruit to your respective organization and how do you make high quality work life happen, how do you make this a profession that people are attracted to, if you have to go to work every day and you have the risk of violence incited upon you, very sad to say, First Hospital in Ontario has put in a metal detector at the front door. We've never ever seen that before. Number of guns in emergency rooms, knives in emergency rooms. It is a changing face. And I want to recognize it's not a one-way street. We also hear sad stories of providers being less than civil to patients as well. And that's a real indication of just how stressed the system is.
Thank you. Sticking with the theme of the pandemic, although moving from the staffing issues, just want to get your thoughts a little bit around the lessons we learned from the pandemic. And are we really ready for the next one? So, Heather, let me start with you on this. You're front and center there.
My children think they learned that I can shut down the schools, and they continue
They like
to do that. They like that. I think we learned about balance and how important it is, and we didn't get it right all the time during the pandemic. The balance of trying to protect people and the health measures we put in, and then the impact they had on businesses, on education, and even more impact in that unequitable kind of impact on certain populations. But we also learned how much can happen and how much we can get done by working together with different sectors. And in a very short period of time, by working across sectors, we got so much done. And we were chatting earlier, how can you make that continue in terms of sort of even some of the innovations that can happen and happen quickly. And I think we learned a lot about human behavior and what happens. We knew it before, but it was certainly great examples of how do we react in times of fear and what we'll do. And there'll be positive impacts as well as some negative impacts. So I think those were some of my lessons to preparing for next time.
Jane, are we ready for the next one?
I don't think we're ready for the next one. I don't think we've learned our lessons properly. There are lots of things that we said in the heat of the moment that we would never do again and that we would be changed forever because of what had happened. And then once our memories became a bit more distant, we didn't really change a lot of the things that we should have learned. I don't think we've done a proper debrief as a country about the decisions that we made. And I think what the pandemic revealed is some values that we're perhaps a little ashamed of and have not taken the steps to confront. And the one that I would talk about is our ageism in society. You know, I think we were all pretty appalled by what we saw during the pandemic about the state of long-term care. And while there has been some progress made and some work towards national standards for long-term care, we haven't really adequately taken those lessons seriously. And as a society, we continue to not put the needs of the most marginalized parts of our population first. And so I think dealing with our aging population and trying to get at some of the things that we referred to earlier around how can we actually fix that and get those people the care that they need, ideally not to institutionalize people because it's the most expensive way to be able to care for people. And it's also not the most desirable and safe way. So there are lots of societies within Canada, societies outside of Canada that actually respect older people in a way that we, in the dominant culture of Canada, I would say have not adequately absorbed. And I think that's one of the things that we deserve, and older people in this country, of which I think many of us might consider ourselves in that category, would like to think that Canada would do better and would actually put some serious spotlights on how we deal with older people.
Jen, you're absolutely right. I think that coming out of COVID, the whole issue of what happened in long-term care homes was a national tragedy, wasn't it? I'm fighting the clock here, so I'm going to try and do a rapid fire here, which will not do justice to any of these questions. But Kevin, new technologies, AI, blockchain, dramatically changing the delivery of healthcare in Canada. Are we adequately investing in these technologies? Are we leveraging properly? How do we get beyond the world of fax machines still in the healthcare system?
Yeah. It's sublime to ridiculous, so we are absolutely investing. I think there are remarkable places. Toronto is one of the lucky ones. Vancouver, Queens is doing some remarkable things. Montreal. There are some unbelievable technology foci that are pushing us forward. I think the challenge of listening to the end of the last panel, AI, generative data, all sorts of big platform and data lakes, new world. Our challenge, I think, will often be as a country, we are reticent to be bold and brave and take risk, particularly as it relates to personal health information. So I hope we're not caught on our back foot, worrying so much, even if we have patient consent, how will we do this in a way that actually keeps us with the first pack of nations? Canada's joined with a number of other countries to wish to do this, but it is a challenging initiative. I think three things we should celebrate. One, philanthropy. So when I look across, Jane and her school just got an amazing gift from Stephen Smith. Next one will be medicine. I hope we'll talk to Stephen. But you know, when I look at what happens at UHN, $250 million a year from our two foundations through philanthropy, most of which is going into research, much of which is going into technology and new technologies that allow us to serve patients better. This is a very powerful healthcare device, right? Everywhere else in the world, you can begin your health journey very aggressively, and we've started that. We have virtual emergency rooms, virtual care. We have you could get your EKG downloaded, et cetera, and we have some of the most advanced scientists working on artificial intelligence and its applications to healthcare. So I think we're doing great. Where we're not doing great is in federally funded research investment, particularly in the basic sciences. We are dramatically falling behind, and I know many of you are not from healthcare, you're from the business community. It matters, right? Basic science investment fuels high performance economies, and high performance economies pay highly trained people, which is what you and your families wish to be. I'll just use a quick example, and it's an old example. It's the steel discussion of Canada. Stelco, let's produce a lot of steel and compete with the world. Dofasco, let's produce very specialized steel. It costs a lot more to make, but it costs a lot more to buy, and we're gonna actually compete head to head on that. You all know the story of Stelco. We don't do very well producing steel against China and its cost structure. When you actually said, but we're gonna take the most sophisticated steel making, and we're gonna expect it to be very expensive, and we're gonna hire the most highly talented workforce, we're also very expensive, and we're gonna compete internationally, that's exactly what happened. And I hope we'll start to take that same approach in recognizing basic research will fuel the future economy of a high quality nation like Canada. we are not big enough to compete outside of that realm. So all of you, I hope, will advocate for basic investment in science at every level that asks important questions that then have commercial application.
Great. Heather, any thoughts in terms of the use of technologies on the public health side of things?
I mean, I think we're dealing with access not just to AI, and I mean that previous conversation, I think healthcare is going to still have a long way to catch up to some of what we heard. But it's really around virtual care that will help us. So it's not just around AI, but around more the technology of virtual access in remote communities and for specialists that we reach. And the sharing of data. So I think one of the lessons learned in terms of being able to gather good research across the country is that ability to share data quickly. And so I think we need the systems to do that. And that would be something that if we could ever get in between pandemics worked out, that would be another, going back to the previous question.
Great. Okay, one final question from me, and then we're going to go to the audience very quickly here. So having here a former health minister, I can't help myself but to ask one of those, kind of quasi-political questions. So earlier this year, the federal, provincial, and territorial governments negotiated sort of an unprecedented healthcare accord, 10 years, $200 billion. A lot of the debate was around, how much should the province be paying versus the federal government, who's going to dictate who. But really, is this the right way about dealing with healthcare? Is this the right kind of leadership? And Jane, you've talked a little bit about this notion of having daring leadership. You want to tell us a little bit about that and how it applies perhaps to this context?
We are desperately overdue for federal leadership on health in this country. We're due for federal leadership, I think, in terms of bringing the country together on a whole number of things. I think we can agree that we are more divided than we have been for a long time. And Canadians care about healthcare. You said the students of Ivy care about healthcare. Global did an ATIP recently on the Privy Council office's polling data and showed that Canadians, when you ask them what's the one thing you'd like to see your federal government fix, far and away above the economy, above housing, was healthcare, way, way up there. So people use the excuse that healthcare is a provincial jurisdiction. That is wrong. Healthcare is a shared jurisdiction. The federal government has a role, the provinces have a role, Indigenous governments have a role. We need the federal government to take serious leadership on health, much more than what we saw in the recent agreements, where there were tiny little efforts at strings and lots of hopes and wishes about what will happen, but there was no serious effort, like the likes of which we saw in 1957 when we first had the access to hospital insurance, in 1966 when we had the Medical Care Act, in 1984 when we had the Canada Health Act. And since 1984, the feds have basically stood back and handed over money with some pretty decent principles wrapped around the Canada Health Act, but less and less attention to what's actually happening out there. And we have reached crisis proportions, and I actually think it's time for the feds to say, look, if you're going to get more money, it's not hopes and dreams we're going to attach to that massive transfer. The only thing that's bigger than the transfer right now is the federal debt, but it's a huge amount of money that goes to provinces without a lot of expectations of what we get. If we have built a country where every child has access to public education at the primary and secondary level, why can't we build a country where every person has a primary care home, a primary care team that they're attached to? I believe that it's doable, but it's going to take enormous political leadership.
Thank you, Jane. I'm sure everybody in this room is probably asking the question, why didn't Jane just stay there and make all these changes? There's still an opportunity, Jane. Okay, I can take one quick, concise question, maybe two quick ones. Okay, you got to make it 15-second question.
For sure. Thank you so much for the panel. This was fantastic. My name is Daniel. I work with Medtronic Canada. As you know, there is an exacerbation of the surgical backlog, and I was wondering on your perspective about utilizing private healthcare temporarily or in a longer run to be able to alleviate this, especially with all the health resources that you're or headcount resources that you're dealing with. Thank you.
You want me to start?
That's a Kevin question.
Everybody said start. I'm just going to start. So You know what? Our problem isn't physical, it's people. So we have no shortage. Most of our operating rooms are actually lay foul after 5 o'clock at night. So it is totally about, we don't have enough nurses. If you're a surgeon or an anesthetist or whatever, you can't work from 8 to 5 and then 5 till 8 and 8 till 11. So it is all about human health, human resources. Personally, I have no objection whatsoever to leveraging private capital. So if we had the need for additional capacity, physical capacity, and it's available, by all means, we should use it. But at the end of the day, our challenge really isn't finding space, it's finding people. And I don't think we're going to turn that around quickly. At the moment, I know where I work, we're doing about 120% of pre-COVID surgical care in order to try to catch up. And that's a long road. So my worry is we're also increasingly contributing to further burnout, because our nurses and then anesthesiologists and surgeons and the team, housekeepers and others, are working a lot of overtime. It's expensive, well worth the investment to get it done. But I don't think the physical plant alone will give us much more than more space. If we don't have the people to do it, all it is a OR table without a team.
Thank you for your question.
This morning we listened to a CEO panel and they talked, one person spoke about the fact that our democracy has become lazy. And in fact, policy is formulated to get votes as opposed to policy being good policy. And I can't think of an area of Canadian society that is more political right now than healthcare. And so my question, actually, as an example of that, all we have to do is look at what happened yesterday in Alberta, where 15 years ago, the Conservative government decided it would be a good thing to create AHS, and 15 years later, the Conservative government has blown the entire system up. My question as a leader in the system is, how do you actually make decisions for the long term, especially in today's environment where everything is so swayed by vote getting? I'm sure there are no easy answers here. Probably not. It's probably more of an approach question. How do you actually go at this given our current reality?
I don't know. Do I take this as an observation or a question? Jane.
I believe, again, that there are some reasons for hope. So it has been sort of conventional wisdom in the political world that you don't run on health because you can't win on health, and you certainly can't win on health in a period of less than 4 years. We have seen in both Nova Scotia and Manitoba now, both a Conservative and an NDP provincial governments who have been elected on platforms that were largely healthcare driven. I take some solace in that, and I think that that's in part because the public has spoken up in those contexts. And, you know, going back to the report that you referenced earlier in the Public Policy Forum, we called it Taking Back Healthcare. And I think we need to really elevate the public voice that we expect leaders, as part of the social contract, to deliver access to care, that is one of the fundamental responsibilities that is required of a democratic government. And that Canadians need to ask for a lot more from what we expect those politicians to do, and to hold them to account. And we'll see if that happens in the coming years.
It's a great response. Go ahead, Heather.
I mean, I think it was Winston Churchill who said, anyone can lead in good times, but it's when bad times that you have true leadership. And so if healthcare is in a crisis situation, we need real courage as leaders to make some really hard decisions that are looking forward many years. We look at the Canadian Substance Use and Harms that came out and said smoking cost the country in 1 year alone in 2020 $11.2 billion in healthcare costs and lost productivity direct costs. If we wanted to do something like New Zealand, where they have said in 2027, anyone born after January 1st, 2009 will never be able to buy cigarettes. So you will end up having a smoke-free generation that will have a huge impact, which will benefit our health care system as well as the wellness of our population. But that takes leadership, and that takes someone who can make those decisions.
Fantastic. Kevin, you had one thought, and then I'm getting the hook here, so
Yeah.
I'll just
Sure.
ask each one of you to just give me a 20-second response
Sure.
in terms of your key takeaways. Kevin,
Well,
you can include that in your
I
final.
will do. So I want to add to Jane's earlier comment as well as this question, and that is actually we need you to make this demand of governments. When was the last time we had a public debate, a leaders debate at the time of an election that demanded parties to put their plan on the table? Not in platitudes. We can't even get a commitment to fund inflation, right? We can't even get a commitment to say we'll keep pace with the other G15 nations. So frankly, we need you to absolutely demand that across sectors. We're the self-interested. When we arrive, they say you're back for more money in health and education. We already spent 70% of our money on you guys, go away. If you want that, every sector of society needs to now say, the next election, you're gonna demand a healthcare debate. And I hope that's something you'll carry forward from today.
Fantastic. Jane, some final thoughts.
Well, I want to thank Ivy for hosting an event like this, and I think it's not by mistake that that healthcare is on your agenda, because business cannot thrive in this country unless we have that social infrastructure that was referred to earlier today, and the social infrastructure includes a fantastic access to healthcare in this country. It is slipping. We have seen what happens when you continue to let it slip. We could develop a system that cost a lot more and got a lot worse outcomes. We do not want to go in that direction. And I think we do need to act together to revive the system, bring it back from the brink.
Great advice. Heather.
I agree, and thank you. I think we do need to focus on some of those risk factors and those public health elements and health promotion to make sure that we are, if we invest in that, we'll also be investing in the healthcare system because we won't be able to sustain our healthcare system without doing some of those fundamental public health focus.
Thank you, Heather. This has been a terrific panel. We haven't done justice to the issue, obviously, but hopefully it's been insightful for you. It's been so much fun to do this. I think it deserves an encore presentation next year. So if they agree, we'll try and do this again. Listen, thank you to all of you. Let's give them a big round of applause.